Good afternoon to you all. Thank you for your kind words, Prashant, and I would like to thank the organizers for inviting me here. I'm aware the lunch is very close, and I'll try and be as brief and quick as possible. I've been asked to talk about transplantation in pulmonary artery hypertension, and the overriding premise is when the organs are beyond salvage, take the bad organs out and replace them with a good organ. So what hinges is most important is the timing of the operation, because this subset of patients, we are dealing with patients whose survival in the next few months, anticipated survival is less than 50%. And we need to be aware also that this is a trade-off. In return for a better quality of life and a longer quantity of life, we are giving up our immunity. So we are exposing ourselves to the risks of immunosuppression. So with that in mind, I would like to go on. To give an overview, I'll talk about the indications and the timing, as I said, our experience over more than a decade, the changing practices we have adopted, and the recommendations of the most recent 6th World Symposium on Pulmonary Hypertension. So I would like to make a point here about two things: a referral to a transplant unit versus listing for a transplant. Referring to a transplant unit does not necessarily mean the surgeon will pounce on the patient and transplant him. We will assess him, look at him, and see where he stands in the lifetime of the patient. If his risks are high, with a high REVEAL score or ESC score of intermediate or high, one needs to consider referral. If there is a progressive disease or recent hospitalization, or has there been a need for a prostacyclin therapy, or signs of secondary involvement of organs, time has come for him to visit the transplant center. And people could be worked up. There are many patients whom we see and say, fine, go back, we'll keep an eye on you, we'll see you back in 6 months' time, and then perhaps think, you have not reached that stage yet. The listing for transplant comes when patients have a higher risk, both on the REVEAL or on the ESC score. There has been a progressive hypoxemia, and there has been progressive. The other end organs are beginning to get worse, so you need to go in before those organs get bad. In such situations, we then list them for transplant, and the average waiting list for lung transplant in our country is around about 3 to 4 months. So this is just a system which shows the risking here. Now this is a slide I want to spend a little long time. If you look at the timeline in the base, on the left side are patients who are too well. Pulmonary artery hypertension, we all know, is an orphan disease, but over the last decade, the improvements in drug therapy has totally changed the way these people behave, and they live longer. So when they are doing very well and being under continuous follow-up, continue to do that. They are all too well for a transplant. The risks from dying from the disease is far less than the risks from dying due to the operation. Don't make the treatment worse than disease. On the right side, when far too much time has gone, patients are far too sick, where you can't even offer them transplant. So the trick is in finding the window, the correct period where the risks from dying from the disease, from the pulmonary artery hypertension, is much higher than the risks of transplantation. So the way we do this when we have patients here is we have 3 simple questions to answer. And if all the answers are yes, we think about a transplant. Has the disease reached end stage? If there is some other option, some other non-transplant option which can be offered, we need to look at that first. And if we have confirmed that he has come to an end stage, all options have been thought about and have not been acceptable, we come to the next question. That is from the patient point of view. Is the patient able to withstand an operation as big as a double lung transplant? So you look at the other organ systems, make sure that the liver, the kidney are all working well. Now, if these two are fine, from the disease point and the patient point, it is okay. The last question I want to make sure is, have I confirmed that there are no medical contraindications, medical conditions which will stop me from doing a transplant? And the one absolute contraindication is a current malignancy or a recent malignancy, less than 2 years. So these are the general indications if there is a higher risk of death, and if we anticipate a post-transplant survival in excess of 80%, and from a general medical point of view, like the other systems are okay, you think about a transplant. Now these list the poor risk factors for a transplant. When the sodium starts going down, the bilirubin goes up, a TAPC of less than 1.8, the presence of CTD, COPD, and the rest. So we have some criteria, listing criteria. So in an idiopathic pulmonary artery hypertension, when there is, despite maximal therapy, NYHA class 3 or 4, there is a declining 6-minute walk distance, a cardiac index of less than 2, and there is an increased right atrial pressure despite maximal therapy of more than 15 millimeters of mercury. So what do? We try and optimize the heart function as much as is possible. Nutritional and pulmonary rehab is important. Of course, we need to make sure they are on supplemental oxygen during mobilization as well, and try and avoid tachycardia during that time. And look closely into liver and kidney for their function. So as we all know, when you have a heart failure, the problems with heart failure is not because of a reduced forward flow as much as it is because of congestion. And organs commonly affected by congestion are the lung, the kidney is cardiorenal syndrome, and the liver, which is a cardiohepatic syndrome. So we'll look into greater detail about the renal function to make sure it is fine, and look into the liver as well to make sure that he doesn't have cardiac cirrhosis due to right ventricular failure, if the enzymes are going up. And we look at the portal pressure, hepatic venous gradient, to make sure that there's not a high gradient, and we don't want to have an acute liver failure postoperatively. So preoperative challenges. Patients who have already been worked up and waiting for a transplant, if they fall off the perch, ECMO is a good option. That is an established indication. We so far have used ECMO as the bridge to transplant, but not for pulmonary artery hypertension. Or the difficulty comes when a patient who's not been worked for transplant comes and lands up in real extremis case. That time we need to make sure he would be a potential person to benefit from a transplant and then put him on an ECMO. Because the overriding principle in a mechanical circulatory support or ECMO is if the disease is irreversible, there's no point doing it. So once, what's happening? That's on. So once we establish ECMO, it's been a practice in our unit to do an awake ECMO. Try and extubate the patient as soon as is possible. And we use a dual lumen cannula, a single cannula down the right internal jugular vein, an Avalon cannula that helps extubate the patient, mobilize the patient, preserve the muscle mass, which is so important postoperatively. I don't know if this video will work. Now that's a patient connected to an ECMO machine. He is extubated and we are giving some physiotherapy there. And this person, of course, is not pulmonary artery hypertension. I just put the slide to show how we handle awake ECMO. And the ideal operation is a double lung transplant for an idiopathic pulmonary artery hypertension. Of course, in selected patients, heart-lung transplant would be an option. Having said that, in our 10 patients of lung transplant for idiopathic pulmonary artery hypertension, we've had to do 8 heart and lung and 2 double lung transplant. And I will discuss why. So postoperative complication, primary graft dysfunction, probably is most in lung transplant after pulmonary hypertension. And the pathology, pathophysiology is quite clear. It's a chronically underfilled left ventricle. It's a stiff, non-compliant left ventricle. You take away the high PVR, you put new lungs in, the PVR is down, it floods, there's a high LA pressure, and they go into pulmonary edema. Handling that is quite difficult post-transplant. As I said, the PAH is highest incidence of PGD after lung transplant, and the highest mortality after lung transplant in the first 3 months is for patients who had lung transplant for pulmonary artery hypertension. It needs a tenuous balance of ventilation, fluid management, and all to support the RV when we do double lung transplant. So a common scenario in the ICU after you do a double lung transplant is the problem of handling the right ventricle. The right ventricle is hypertrophy, and then it can physiologically act like a right-sided hokum, an RVOTO. So too much of congestion, too much of fluids, the left ventricle, the small left ventricle can't handle it. If you give too little, there is not enough filling pressure, the RV collapses, there RVOT obstruction, and we have it. So much so, there are some centers who are beginning to rethink and wonder, should we perhaps do heart and lung transplantation rather than double lung transplantation? But given the number of patients on the waiting list and scarcity of the organs, still double lung transplant continues to be an option. I'll just quickly go through a slightly challenging, a technically challenging case. We had a heart-lung transplant done in a situs inversus totalis. We've done 3 heart and lung transplantation in situs inversus totalis. The other 2 were for the more common ciliary dyskinesia syndrome with bronchiectasis bilaterally. Of course, one, which I'm going to show now, is for a patient who had an idiopathic pulmonary artery hypertension. So the problems that surgeon has is the donor invariably is going to be situs solitus. The recipient is situs inversus totalis. You take all these organs out, the cut end of all the tubes are lopsided. So you need to be creative in trying to reattach them. So there's a 35-year-old lady with an end-stage heart and lung disease, a situs inversus totalis, severe RV dysfunction, TAPC of 8 with an NYHA 4. We did a 3D printing before to get a feel of what these are going to be and how I'm going to plumb them back together. Now, if you see the left-sided, there is an absent aorta on the left, and the SVC and the IVC, the venous structures, are on the left side. On the right lateral view, it's very important that you can see there is no atria on the right, there is no venous structure on the right, and the aortic arch is on the right side. The posterior view shows the right aortic arch going down and the descending thoracic aorta on the right side. So these are some operative pictures where it shows all your venous structures are on the left side here. We put the patients on bypass. Normally the venous pipes, which you see on the right side, would be on the other side. So we have taken it out, and that shows the cut end of various vascular structures. The heart-lung graft, the donor, was situs solitus. Doing the tracheal anastomosis was the easiest bit because in both the trachea is a midline structure. Aortic anastomosis too was not too difficult because we had long donor aorta. The challenge was in the venous anastomosis. So when we were harvesting the heart-lung block, we also got the innominate vein as well. And the cut end of the innominate vein was anastomosed to the recipient's left IVC. So that was also easily sorted. The only trouble we had was to stitch a right-sided IVC to a left-sided IVC cut end in the recipient. So we had more of the recipient RA cuff and managed to stitch them together. And these are the various anastomoses. That is a line diagram of a completed organ, and that is the postoperative coronal section of a CT scan. You've got now a levocardia, but if you see below the diaphragm, you've got the left-sided liver. So that was one of the challenges that we had. Now, talking about the changing practices, when we started our heart-lung transplant, in 2007 was the first lung transplant that we did, and we followed the Cambridge protocol for induction therapy, and the patient as induction received ATG. He survived 5 days and then succumbed to a very rapidly progressing pneumonia. We didn't have an ECMO support then. And then we revised our thinking and thought perhaps in India the conditions are a little different. So why don't we soft pedal on the immunosuppression? And we then followed the Hatfield protocol, where there is no induction even now. And there was no induction therapy. Now, more than 15 years down the line, we are beginning to see patients after lung transplant, 5 years, 6 years down the line, with CLAD, chronic lung allograft dysfunctions. So now we had a revisit, and we thought probably we should go back to starting to use basiliximab as an induction therapy in day 0 and day 4, and that is now what our current protocol is. So this is a little outdated slide. We did our double lung transplant 1 week ago, which hasn't been added. 125 lungs and 67 hearts. The double lung transplant is about 33, 4 bridged from ECMO, 2 from ECMO and 2 from ventilator. The number of single lung transplants have been only 7. The survival, as you all know, the survival following a lung transplant depends on the disease for which the transplant was done. And the best survival is in cystic fibrosis, followed by idiopathic pulmonary hypertension, and ILD is always the last. In our series, we have had an 80% survival, and these survivals are 1-year survival, not immediate survival. We have a 66% in ILD for many reasons, because patients here are normally quite late in their referral. So our data for pulmonary artery hypertension, we've done 10 patients, 8 had heart and double lung transplant, and 2 had a double lung transplant. The 1-year survival is 80%. We lost 2 patients. One was immediate post-op, within the 5 days that I told you about in 2008. The second was a patient who did very well, survived, went back, but developed a pseudoaneurysm of the aorta due to pseudomonas. We got the patient back in under total circulatory arrest, repaired and excised it, but we were not fully able to eradicate the infection, and we lost her. Regarding major complications requiring ICU stay or intervention, we've had PGD in 2 patients. One we were able to manage conservatively, i.e. not using ECMO, and one required the use of an ECMO. Now this is a patient that you can see on that side. It's post-double lung transplant. You can see the clips of the clamshell incision, chest tubes in there, and nearly white fields. We put them on ECMO. You can see the ECMO cannula on the internal jugular, and there is one coming down from the abdomen. It's a jugular-femoral veno-venous ECMO, and that is the resolution post-ECMO. Situations specific to India, there are 2. One is TB endemicity. The TB endemicity is both in donor and recipient. In recipients, you have the luxury of time. You can work the patient up, make sure he has no TB, or if he has TB, treat him and then list him. Whereas with donors, we don't have the luxury of time. The relatives want the disease as far as possible. So to the extent possible, we do a bronchoscopy, blood gas, chest X-ray, and then go for it. The second is late referral. Of course, referral practices have been changing, mainly because we've been having these meetings of these sort, and physician awareness is increasing. Perhaps the most important thing for the physician is for him to have confidence on the surgeon. If the patient is only a one-way traffic, he goes to the surgeon and then goes to meet his maker, the physician will not want to refer it further. If the patient goes back to the physician, then they begin to think of a transplant as one of their options. Now that has been improving of late. The second is, it is the attitude of, the default attitude prevalent in India, where any operation suggested, the question is, doctor, can't we have any medicines? Can we avoid operation? So they would try, and endurance is supreme here. They would put up with any symptoms until it comes to the last stage when they say, do what is possible, get me out. But by then they would be on the right hand of the graph that I showed you before. It's too late for transplant. So we had a challenge in trying to get this program off the ground, because the patients that we got were invariably late. It's pretty much like when intra-aortic balloon pump was put in. It came in, they said, it's used for patients with poor LV, but they waited until the LV was so poor, he was on end stage, low cardiac output, then put a balloon, the patient died invariably. Look, IABP has killed the patient. So the timing, the referral is more important. We now know when you put prophylactic IABP for a poor patient with a poor ventricle, before your coronary artery bypass graft and do it, patients do well. Now, IABP is now an accepted therapy. Similarly, in India, I think lung transplant is beginning to be an accepted therapy. We tend to give a lot of physiotherapy because low muscle mass and frailty affects these patients. So while he's on NIV, we get to do these on the ICU bed. Now, this is post-transplant. One important thing is after you do a transplant, you have denervated the lung. There is no way he can cough the secretions out. So we put a small tube down the trachea. It's a mini-tracheostomy. It's not a ventilating tracheostomy. It's only about 2 millimeter size. So we put in a suction catheter and suck it out once he brings it up there. Now, that is the cannula down in there. Now, this is in a heart and double lung transplant, because you can see the cannula in the trachea and you can see the Anastomoses in the trachea. So it's a heart and double lung transplant, the carina further down there. So talking about the recommendations by the World Symposium, repeated risk assessment is necessary. Once you go into the high risk, refer them to a transplant before it's too late. You have established and validated risk prediction scores. Timing is very important, and it has to be factored to the local waiting time as well. bilateral lung transplant is still the method of choice in patients with IPAH, and there is no degree of right ventricular dysfunction that precludes bilateral lung transplant patients in IPAH. That is a recommendation, although from the Indian scenario, I'm not quite sure I would entirely agree with that. Because these people say after transplant, put them on ECMO for about 6 days till the RV improves. Whereas when we put our patients after transplant with immunosuppression on ECMO, the problems with the infection come in. Despite ICU advancements and extracorporeal life support, the ideal recipient is an ambulant recipient. What I tell my patients is, you walk into hospital when I call you for a transplant, there's a high chance you'll walk out of hospital. Extended use or ECMO support should be done in patients to prevent graft dysfunction. Given the low number and the high risk of transplant, it's better if it's done in a specialized center. Thank you for your attention.
Thank you very much, Dr. Sunder. It was very enjoyable, and we congratulate you on your outstanding experience. Thank you very much.
Thank you.
I've got one question to you, and from your experience, what were the indications for the single lung transplants?
Yes. We have the luxury in India, since lung transplant is just beginning, we don't have so much on the waiting list. So ideally, a double lung is better. Single lung, the problem in PAH, I'm aware of papers which say you can do single lung there. The problem is once you have a native lung, which still has a high PVR, the right ventricle floods this lung, and this new precious graft is subjected to overflowing and a high incidence of PGD. So I think perhaps at this point, what the literature says is there has been no difference in survival in single lung in IPAH, ILD, or COPD. But if you consider single lung versus double lung in IPAH, the initial bump, the initial postoperative mortality is high in single lung transplant. But technically it's easier. It's 1/2 of the operation. Whereas double lung, I have to do it twice. Single lung is much easier.
I have a question, if I may. Thank you for a fantastic talk. As a transplant surgeon, how do you feel about the prospect of doing a bilateral lung transplant on someone who had a pot shunt 10 years earlier and maybe has adhesions and developed collaterals?
Yes, I mean, that wouldn't stop me, especially if it's someone kind like Mohanty who's done a graft. It's an easy job of just clipping the graft. But what we've done is, ideally the operation for a heart and double lung transplant is a sternotomy. We've had patients who had pulmonary atresia and huge MAPCAs. And these MAPCAs come from the descending aorta. There's no way I can reach it through a sternotomy. So we do a clamshell, just open it up in a clam, you can see everything else, and go ahead and do. Previous operations will not stop us, but we will try to liaise with the donor family, get some more time, so I'm already on the job preparing and have the chest field ready to implant as soon as is possible. Sorry? Yes. It's the early part of the career. People start coming pretty late, and we needed to get the program off. So when I saw that RV, I didn't have the courage, because I do it and I lose it. Then again, they'll say, yet another transplant patient died. So we need to think of that as well. But now, with increasing numbers, we are able to handle any RV.
Dr. Sunder, there was a fantastic talk and provided a lot of insights into lung transplant in our country. Do you have any experience with the Nova lung?
With the Nova lung, we were about to do one, but no, we don't have anything. It's, as you know very much, it's only for carbon dioxide removal. You don't need a pump. The patient's own arterial blood pressure drives it. It's of great help in a carbon dioxide retainer. So if you have a PCO2 of 120, 130 with a pH less than 6.5, you put that, it becomes life-saving, and then you wait for a good organ to come. Double lung versus heart lung. Well, assuming the left ventricle is okay, During our cardiac assessment, we look at the heart as a whole, providing the coronary angiogram is okay, the left ventricular function is okay. The evidence says, however bad the RV is, just plumb 2 lungs in and it will get better over time. You may have to support the right ventricle for 3-4 days soon after transplant. The other technical reason, once we had to do, you asked me why, the other reason was they had giant pulmonary arteries. The diameter of the pulmonary artery was 7 and 7 centimeters. And the diameter of the pulmonary artery in the donor is max 2 centimeters. How am I going to plumb these two together? So we had to use, for some technical lesions, heart and lung. But physiologically speaking, a double lung transplant, if the left ventricle is okay, if the coronary anatomy is okay, it all comes back.
Dr. Sunder, I don't know anything about lung transplantation. That's a disclaimer. My question is, what about living donor transplantation, lung transplantation, where the lobe is used?
Yes. We plan to start that soon in our unit. There are only 2 centers in the world. One is in Japan, other one is in America, who do live lung transplant, live related. Most often it is done in children with cystic fibrosis. Both the parents, one lung is taken, providing their ABO group compatible, which they normally are. So you do a pneumonectomy on both sides and use the lower lobes, left lower lobe for the left side, right lower lobe for the right side, and do that. The results, the Japanese surgeon claims, is fantastic. And this can be a planned procedure. Unlike a diseased or a cadaveric donor, you don't know when. This you can plan, work the patients up and all that. Having said that, the one thing a transplant program must never have is the living donor mortality. And lobectomy, even in the best of centers, even Sloan Kettering, have got a mortality of 2%. So it would be a shame you do a lobectomy and for some reason the donor dies.